So Dr. Anoop Gupta.
Yeah, good evening. Can you hear me?
Yes, yes, loud and clear. Very good. Please go ahead.
Fantastic. Yeah, thank you very much for the opportunity. I've got my all team, like, on my left, Dr. Vashish is a critical care. Joel is my colleague, intervention cardiologist. Abhishek is our structural man and the tech and everything. So what we have been assigned to do is an OCD guided bifurcation lesion. So what we planned. Next slide, please. So what we planned, this was the case. Proximal LAD, tight, fibrotic, 90% lesion. And if you see the cranial view, large diagonal bifurcation, almost 90% lesion. And the plan was probably rota or IBL with OCT guidance. Unfortunately, this guy developed severe urinary tract infection, counts more than 20,000. Obviously, we cannot do the case today. So what we are doing is a backup case. Next slide, please. So next case, he's a 62-year-old gentleman, hypertension for a long time, recently detected to have diabetes, only 2 weeks history of angina, ECG, sinus rhythm with incomplete RVB, echo normal, subjected for treadmill. It's strongly positive in stage 1. Angio performed, showed osteoproximal 80% lesion in LAD with a high diagonal ramus arising from that, and got a normal creatinine. Next. So you can see the baseline ECG on the left side, which is like incomplete RBB, nothing. But if you see the first stage TMT, very really, really scary. So now the question is now show the first picture. Now there are a couple of things it's a true LAD osteal lesion. So whether we need to do a true osteal stenting of the LAD, one thing, or we need to do a crossover from left main to LAD. So obviously, circ again is a big vessel, although it's not a dominant vessel. And you can see very well, you can see one very big diagonal coming from the proximal segment. Next view. So it's a little longish lesion, almost like 32, 33 millimeter. Next. And so we wired with the Watsatan Abbott wire. Next. And the plan was to take an OCT run. Next. So we took a OCT run, and the OCT pictures you can see, and Dr. Joyal will explain the OCT.
So we started our OCT from the distal edge of the lesion, and the area which we got was EL to EL was around 3.2 with area of 3.19 mm square. MLA was 1.6 mm square. The lesion is mostly fibrolipidic at the tightest spot, and there were some mild deep calcification seen. The ostium of the left main, ostial of the LAD was diseased, but distal left main is disease free, and diagonal origin angle is also around 60. So we could anticipate that it will not close during the intervention. So here's a OCT run.
So the plan is we are thinking of doing a cutting balloon. Probably we are going to do with a 3.5 stent. So we are thinking of using Wolverine 3x10, and after cutting balloon, we are going to wire the diagonal, because we think that probably since the distal left main is absolutely normal, probably we'll get with the true ostial stenting. So what is the opinion of the experts in the house? What do you suggest?
So can you show us what is at the ostium of the LAD?
Yes, please show the OCT.
Yeah. How much is the plaque burden there?
Just focus the ostium.
And this OCT run is without pre-dilating the osteum?
Yes. We after the LED wiring, we have taken the first OCT picture. The plan is after cutting balloon, we are going to do OCT again, and then we are going to stent it.
Yeah, that would have been better, because you do not know the distal artery may be in spasm, and that's why you are getting area of only 3.2 with 1.6 millimeter diameter.
Correct.
Yeah,
Although we have given NTG, we have given twice NTG before taking the OCT.
So let's see your ostial LAD.
Can you see that? Ostium of the LAD. Yeah, we are focused on OCT, the ostium of the LAD.
Yeah, that's the ostium. And
yes,
what are the sizes? Look at the lipid pool over there.
Yes.
Yeah, it is there.
Over there. Yeah.
Yes.
I think
even if you see that there is some calcification also at the LAD ostium.
Correct. Yeah. Area is good, but there is a lot of lipid pool over there. What about the distal left main? Let us see the.
Yes, you will show that thing.
Just show that.
Show the distal left main. Here you go. Distal left vein absolutely clean.
Oh, yeah. And what about the Sir costume? If you can see on the
Yes.
Sir,
bifurcation
costume looks,
view,
yeah, looks okay. Looks okay.
Okay. But
Yes. Yeah. Just, yeah. Show the sir costume.
in the bifurcation mode, if you can see
Raj, can you make it
the
bifurcation?
Sir costume.
Sir costume.
Yeah. Yeah, looks good. Okay, so you want to nail the ostium.
Yes.
That is what we are planning.
Okay, let's see.
So we'll do cutting balloon. So this is 3x10 Wolverine. We are going to go with the cutting first, and then we'll take a OCT run again, and then we'll assess what is to be done.
So what size Wolverine are you going to take?
3 into 3x10.
And till what atmospheres will you go?
Oh, we probably go up to 8, maybe up to 12, not more than that.
What
Like,
is
you
the
know,
size on
people-
OCT of
It's
that?
around, it's 3.2.
EL.
EL to EL is 3.2.
Okay.
Okay, Dr. Anoop Gupta, so you're going to do all that or have you started already doing it now?
Oh, we are going to dilate now with the balloon.
Okay, so we'll come back to you in about
That's-
10 minutes.
That's fine. That's fine.
Thank you.
Give a new
Go
invite.
to Ahmedabad.
Huh?
Oh, we are with the Joyal and we are,
Okay.
we are back
Can
with
you
you.
hear us? Can you hear us?
Yes, Anup, we can hear you.
Very big
Okay.
sound.
So yeah, VT, the other thing, when we are talking about Anil, so Ahmedabad, everything is radial. So our is also 7 French radial only. And we took 7 French guide. Only thing is because we were not sure whether we are going to do a crossover or we are going to do true hostile. So, okay. So this was a 3 into 10 Wolverine. And finally we went up to 16 Wolverine because see, it was a very tough, it was not cracking up. Yeah, front, go up. And then we dilated the ostium also. So next, so we dilated the ostium also. And then, oh, no, don't go so fast here. Okay, so this was after cutting balloon. So, you can see a lot of dissection. And then we took a OCT run after cutting balloon. So show the OCT run. Can you see the OCT run?
Yes, yes.
Yeah, we're going.
So nice dissection in the OCT. We have cut all the fibrous plaque, which was, on angiography, it was not looking so bad. Probably most of the time we would have gone with the NC balloon only. But, after doing with the cutting, we thought that, probably we have done the right thing. So, and then the EL to EL after the cutting balloon was almost like 3.55.
Distally. That's a distally.
That's the distal one.
And
Yeah,
there are
so you
two
can
cuts.
imagine now how much did it expand after
Yes.
the dilatation and.
Yes.
So
yes.
now let us go to the ostium.
next,
to see
Yeah.
What happened to the LAD ostium.
Yes. Show the ostium.
There's a. It's good.
So can you see the ostium?
Not yet.
Yeah, there's the ostium.
Ask him to freeze it there.
Yeah, he'll freeze.
Yes. Okay. So what's the size there?
It's 3.15.
Oh, no, you cannot. It's actually the luminal
No,
area.
3 point, sorry. It's 3.5. It's 3.51. It's 3.51.
Yeah.
EL to EL is actually 3.6.
3.51. I think it's a 3.51.
No, we wanted to understand that 3.6 was the EL to EL in the distal part of the LAD, right?
Yes.
So here it is definitely, that is the problem. Here we cannot measure the EL to EL perfectly because under size you can't understand very clearly. That's the
Right.
distal is 3.56. Probably it is a 4 millimeter vessel. Diameter will be 4 millimeter vessel. He is in the EL to EL. Actually, it's a luminal area or what are you talking?
Which one? The luminal area is almost, the area is 8.6.
No, luminal diameter. Actually,
Luminal diameter is 3.3.
3.3 is the
3.4.
luminal diameter. Vessel will
yeah.
be probably 4 millimeter vessel because
Yeah.
distally is 3.6. So
Okay. So next, so means next, so we wired next. So we wired the diagonal with the run through wire. Although, means we could have
answer.
put a wire after stenting also. It was not a bad angle and all thing. And then we took 3.5 into 33 Zines alpine stent. Yeah, show the stent. Yeah, okay. Next. So we position
point-
right at the
You
ostium.
finished that? Okay, I was just about to ask you, how about putting a wire in the circumflex? I mean, you wanted to nail the ostium of the
circumflex-
LED.
Yeah, circumflex angle is so good. I can put the circumflex wire anytime. That's not an issue.
Yeah, but you
And
never
it's a
know
very,
whether,
it's a
if
very
the
big
stent
vessel.
studs come proximally in the left main, you will never know the wire will go in between the struts.
Yeah,
Anyway,
that's
so now
true.
let's see
Yeah, yeah.
now.
Next,
Let's see.
next.
Basically, what we are actually trying to do, it is a teaching program. So people actually, if you tell you're an excellent operator, you can do that thing. But will you advise the people and people to do the case? Will you tell them to do put a wire in the circumflex or not?
Yes. Pratap, yes. Ideally, you should put a wire in the circumflex for sure. But since the angle is so good, the circumflex vessel is almost 4.5 millimeters. So, most of the time we think like, probably if we need to wire the circumflex, we can wire anytime. So, putting 3 wire again, we thought that we will do with 2 wires. And we wanted to keep patency of the diagonal also, because we after doing cutting balloon many a times, what have we seen? Like, because of the cut, sometimes
You are having a point for, we are actually just telling the people that you have to
Yes.
keep a wire into the
Yes,
circumflex
that's
as well as diagonal will be ideal in this situation. But in this case, you are actually able to do putting a wire to the circumflex is easy for you. So you are not putting the wire. Correct?
Absolutely. Yes. Next.
Many a times, wiring the circumflex when you are doing ostial LED stenting, it helps in anchoring. So the movement of the stent is less, so that you can accurately place the stent.
Yeah, right.
So that also helps in anchoring also.
Secondly, the position also.
Positioning and
See,
anchoring.
there are
both.
people who just keep a balloon over there
Yes,
without inflating, just keep a balloon at the circumflex ostium
yes.
as a marker. Today morning we saw
But
Joel.
even then, actually, I'm
Also,
just
you
telling
can
you,
use,
just putting a balloon alone cannot do. You can actually dilate with a novel atmosphere, 4 or 5 atmosphere pressure and keep it. That's one way. Number 2, you can do, earlier people are doing a sabo technique where also this actually works out, keeping a wire into the circumflex.
And also many a times if you use in newer
Saurabh,
machines, the clear stent imaging,
You
clear
tell
stent
Saurabh,
imaging,
that
that
also.
you inject and you see place the stent there, inject and take a
With
clear stent
contrast.
imaging. You can clearly see the contrast going and you can accurately place the stent at the ostium of the LED. Clear stenting also helps.
So Anoop, now let us see now what happened.
Yeah.
Let us hear from Saurabh.
Yeah.
Saurabh, what
Okay.
will be your way of doing this?
Yeah, I think so. When I look at the OCT imaging here, it seems to me that the ostium is spared. I think the stent positioning, especially with the long stent that the team chose, shows that the stent is not scissoring as much. Sometimes when it's going back and forth, it's easy. So I could go either way here. I think for the young operators, it's always a good idea to protect. You can't go wrong here. Obviously, with any wiring you have a small risk of complications, but here the wiring upfront is straightforward. And I do worry that if you have 1 or 2 stent struts hanging into the ostium of the circumflex, that could sometimes become harder. But I appreciate your point that it should be relatively straightforward to wire. And then I'm not too concerned about the risk of plaque shift, since I didn't really see any plaque into the ostium.
Moreover, actually, when you
Alright.
do a radial route,
Yeah.
the movement
But
of the
in
catheter
this
will be
case,
more
don't
than
forget,
the
there was a lot of fatty material there. Lipid pool was there at the ostium. So chances of that lipid pool shifting to the surf ostium is also we have to bear in mind, depending upon the plaque morphology of the lady ostium. You agree or not?
Yeah, better to be safe than sorry. And that's all we have to say about it. Okay, show us what you have done after putting the stent, Dr.
Yeah. Okay, so this was stent was inflated at around 12 atmosphere pressure. Next. So then we again rewired the diagonal before post dilatation.
You did a
So
pot.
this Oh, we are going to do pot with a pot balloon of 4. Next. So we did, we dilated the distal segment. See, if you see the distal part of the stent also, it still seems underexpanded. So we have dilated with 3.5 into 15 balloon at 20 atmosphere. Next. So this was the stent boost. So we have gone very high pressure with the 3.5 NC balloon. Next. And we are almost ready with the pot balloon 4. So, we are almost ready with the pot balloons here. We're going to perform pot with the 4O. And then we are going to take the last OCT run.
Okay.
Pot
Next.
balloon is actually pot or pot balloon or a normal balloon?
No, it's a pot balloon.
Pot balloon, what is the
Yes.
size of the balloon you took?
4 into 8.
4 in weight. It's a pot balloon with this side
Yeah.
extension.
Okay. If you are going to stay with me, give me 30 seconds. And my balloon is going to get
Yeah.
in.
Yeah,
within
we'll be
30
with
seconds.
you. Just finish off and then we'll move
Oh,
on.
yeah. So my pot balloon will come. Go to spider view. Or RF is fine.
You don't want to
So-
see the imaging after that.
Yeah.
Yeah,
Just
Very
wait 5
good.
minutes.
Come back.
He's going
maybe-
to be.
He want to demonstrate the pot balloon.
Okay. Oh, give me 3-4 minutes. So, I will give you OCT. also.
Sure.
No. Pot balloon we want. We
Yeah,
definitely.
there's the pot balloon. So, okay. Ready for boost?
That's it.
We are seeing OCT. Please switch over to the angiogram.
Oh, show the pot balloon. Show the main screen.
Main screen.
Ready for boost?
No, please. But yeah, okay.
So-
Yeah, that's fine. I think that's fine. We still have to.
Yeah,
it
दे देते
back.
हैं.
Yeah,
We'll
go ahead.
come
Go
back.
ahead. Yeah.
थोड़ा और पुश करते हैं तो अंदर से पीछे
Okay.
थोड़ा और, हाँ बस ओके नॉमिनल
You want to show the balloon?
Ah.
Oh, you can show the pot balloon. That's not an issue. Okay, store. Okay. Ready for boost again?
आरओ मिकल
Ready for boost? Yeah, can you see the pot balloon?
Yeah, but, okay, now we can see the box.
We want to see the.
The stent boost.
Okay,
please.
okay. Yeah,
Let's
sure,
boost.
sure.
Yeah.
Yeah. That is I'm going to show you.
Actually, we wanted to
yeah,
see
fine.
the positioning of that balloon for the pot. That would have been possibly better seen in a PA corder.
No, okay, we'll go that. Even, we can make an RO crane. RO crane will be better. Even
Fine.
make PA call. Make PA call. If PA call is good, we'll show. Otherwise, we'll show you in RO crane. Probably RO crane will give you a very nice stent
Good,
boost.
yeah. That LAO caudal foreshortens and then you don't know whether
Ready
you
for
are
boost?
over the ostium or.
Ready? So, VT, this is PA caudal.
Yeah. And now
Show
That
show
will
us
go
the
with the dye,
stent boost.
then we would know exactly
Okay, with the
the
die, okay, we'll do that.
origin and the marker.
Okay.
Is
Send
this
us
a
again.
cement system?
No, this is G.
There's no need of it.
Almost,
Actually, you are
almost.
doing a stent boost and understand where it is.
Correct.
Yeah, just show us the stent boost. We can't see the stent boost. And
Okay, so somebody has to focus on the stent boost.
सेंटर फ्लोरो थोड़ी વધારે ખુલ્લું રાખ ભાઈ ઓકે સીન
So in the screen, can you focus the send boost on the screen, somebody? नहीं होगा ये वाला screen, ये यहाँ पे monitor वाला screen में नहीं
Second.
होगा, second वाला screen.
तो और पुश कर लेट अस पुश
you may be coming into the left main. I
Yeah,
think.
yeah. It
Yes,
looks.
yes.
वी आर पुश
Yes, we are pushing the balloon inside.
Yeah. So it's 8 is probably slightly larger. 6 would have been probably
Okay.
better,
Hold on.
I think. But
Yeah.
either way, that's okay.
I was about to ask, what's the distance between the diagonal origin
Yeah.
and the LED ostium? Doesn't look like 8.
It is 6
Yeah,
points.
it's 5 millimeter. It's 5 millimeter. It's a very high
It is
diagonal, almost
6
like a lemur
millimeters,
straight.
not more than that.
स्टैंड बूस्ट रेडी कर
Ready?
Yeah.
Inject. Okay, that's fine. That's fine. I think this fine.
एक से
This fine.
This fine.
This fine.
Yeah, that's okay. Go ahead and inflate and do an OCT, please. And
Yes.
Yeah.
Keep OCD ready. Okay. Store.
निकल दो
So what is the house opinion? Like we did the right thing, Neil lost him, or anybody would have gone crossover from left main to elite in this situation?
I want to see the imaging.
Okay.
Anyway, you have done, so now we
Yeah.
have to see the imaging and understand that.
No, just giving the anatomy and giving the pictures and giving the circostium and previous OCT before dilatation after dilatation, anybody would have gone, anybody would have done something different or the same thing?
No, we thought you had enough room for the osteo.
Yeah.
Correct. That is what
placement.
yeah, exactly. Means with the first OCT run, we were quite confident, like, probably we have got enough room in the ostium. So, we can put the proximal marker right at opposite to the circumflex, and then we can just nail the ostium. That is what we thought also.
Yeah, that's what
Okay.
we felt, that you had enough room to land.
Sort of actually in any osteal LED lesion, when you have a
Okay,
restenosis and the
okay.
patient coming back, the chance of high restenosis is definitely there. It is actually the crossover is always safer for an operator, safer.
Yeah, Pratap, I agree with you. Like, again, we were debating, like, one stent or two stent strategy in case, like if suppose we are going to do crossover, because left main is almost like 6 millimeter, 5.5, 6 millimeter.
Any comments from the audience? I think somebody.
Anybody have some
Yeah.
comment, please?
Can you turn the mic?
Can you give the mic, please?
Mic.
Mic.
NTG.
Okay.
Okay, we are ready for the OCT run.
Can you give the mic and you
They're bringing it. Yeah. In the meantime, you can go ahead with OCT.
Tell me when you're ready.
First, I would like to know in what view the positioning of the stent was done in the ostial LED, because most of the projection was in the alveocaudal view, and there might be the foreshortening in that view. So proper landing of the stent struts at the ostial part may not be correct in that view, and no PA caudal or RA caudal view was taken. Second thing, which stent was used and what was the gap between the marker and the stent struts in that stent? Second, when we took the angiographic view, last angiographic view after deployment of the stent and the pot was being done, I could find out some geographical miss in the ostial part.
Right. So
You mean to say,
you are right,
while
we should-
Let him answer.
yeah.
Did you hear all the questions? You please answer.
Yes.
the questions.
So the first thing, like, we assessed in two views. One was RF cranial and second was alveocaudal, which was 45-45. And I still feel like, to nail the ostium, probably alveocaudal is the best view. And the second, if you really want to see, probably I would go for a RF cranial view. One thing. So, means, yes, I will. My word is taken, like, probably if you want one more caudal view, you can do that thing. We can do we can take another caudal view, like probably like a PA caudal or RA caudal. The other thing, the stent we took is a giant alpine stent.
Can we see the
OCT run.
OCT,
Can we see the
OCT.
OCT run?
Yes, the previous one, you have that, Raj. We have taken one OCT run. You have that.
Can you show it on screen?
Yeah, we are going to take one more because he said that that was not adequate. So,
Okay.
Okay.
okay, your catheter is in, right. Yeah, keep going. So we will take one more OCT run. That's not an issue. Okay.
Hello. Can I have a question?
Yes, so the stent was Zions Alpine 3.5 into 33. And we expanded the distal part of the stent with 3.5, 15 NC balloon, and the proximal was pot balloon 4 into 8. And the other thing, other question was that the geographical mismatch. So let us see the last picture of the OCT image. So we will come to know whether there was any geographical mismatch or not.
From audience.
Actually, I just wanted to understand that normally
Dr.
the
Gupta.
practice had been the crossover. I don't see any harm of doing crossover. Do you have any negatives as compared to doing the ostial stenting, which requires so many manipulations, so many angles, and still there is a risk that you may have the geographical miss because of the stent or because of the other regions. Whereas when you have crossover, I don't see any harm. I don't see the type of the ostium you have, circumflex, the left main, which is so roomy. Practically 0% chance of any complications doing the crossover.
Yeah, just
Oh, you're
one
right.
doctor.
Like,
Yeah, Dr. Gupta, I think your guide is not being deep, so you're not getting good pictures. But meanwhile, you're right about crossover. It depends upon how bad it is, the ostium part is involved. I prefer, if the ostium is truly involved, I prefer crossover, as Pratap said. But we only have 20 minutes for the entire 3 cases. So let's look at this OCT. I agree for the audience, somebody
Actually,
asked.
Ramesh, the question Rishi asked me, basically the answer is you have a size mismatch. That makes people to think that whether to do a ostial LED stenting alone, that is a major point. I think otherwise,
Okay.
always, that's mismatch is actually size mismatch. 6 millimeter to 4 millimeters, 3.5 millimeter. That makes people think, number one. Number two, a complicated case, rewiring, if at all there is a plaque shift, all those things people get into the mind. As Rashid told, always safer things to do for a easy way of doing. Multiple manipulations are not required. Single crossover, proximal part, dilate very well and keep the stent post in the LMCA will make our life easier.
Yeah, we crossed over here.
Yeah,
So
we crossed over. We have crossed over already.
Yeah.
So now you have to do a good part.
Where the question of Manish
because-
Mittal, Manish actually asked one question.
just
That projection, he could not identify exactly the ostium is placed or not. So the exact ostium by people is not exact ostium.
that's why the question
And
was.
secondly,
So
I
I-
believe when you are doing radial, there is lot of movement. Respiratory.
This is what I'm telling. Ostial stenting, radial has a problem where robotic angioplasty or a femoral intervention is better.
Yeah.
I just want to make a comment about nailing the ostium. And morning also, I think we had discussion on which view will be the best one to identify the ostium. What we have to understand is the coronary anatomy is a 3-dimensional structure. No two LAD origins are the same. They can originate in different angles. So the ideal view varies according to the patient. It may be PA caudal, it may be RAO caudal, or it may be LAO caudal, or it may be RAO cranial as well. So we need to choose and find out which view is the best for that patient to identify the ostium. You cannot generalize that this is the best view for all patients to nail the ostium.
So Justin, you tell
Okay.
the 3 views, which best 3 views you can use. Tell
Right.
me best 3 views.
So I'll prefer, PA caudal, RAO caudal, and RAO cranial, and LAO caudal as well. I'll say 4.
So 4 views.
Of these
So out
four-
of the 4 views, we have to select
We'll
2
select
or 3.
2 or 3 best.
So that is what is Justin till, and if everybody agrees, we can agree with that.
Dr. PK Goal's publication. We'll wait for that. So thank you, Dr. Gupta. We really thank you very much for showing this case. I think OCT looks good.
I think there are 2 to 3 millimeter stent inside the left main. So I think that
Okay.
is fine. That's fine. I believe.
Okay.
Okay.
It's okay, actually, we
Okay.
accept
There's
that.
no dissection. Everything looks
Yeah,
good.
yeah,
very good.
You post dilated. You did a pot already.
Yeah.
And thank you very much for this demonstration. And any final words?
Gupta,
Pleasure.
any final word?
Final word. Thanks a lot. Obviously, the question which came, whether it was crossover from LMCA, initially we thought that probably we will land up doing a crossover from
But there is
LMCA.
no harm done. You please check the OCT again. What was the diameter and
No,
now
I think it is
Okay,
wonderfully done and we are just winding up.
Thank you very much. We are done with you. We congratulate you for
Great.
this fantastic job.
Thank you very much.
And we'll move on to the third.
Thanks from our team, everybody from Ahmedabad. Thank you very much.
Thank you, sir.